Okay, so the chief complaint is pain at the base of the head and the back, along the atlas line at the base of the skull. Not a little pain, a lot of pain, debilitating pain. And these concussion symptoms that come and go. So you had severe unrelenting concussions symptoms from 2002 to 2008. The NUCA doctor adjusted you from the right, you can come around here, and really got you out of that tailspin and did really good by you. And then it got to where it wasn't working anymore, and it seemed to just kind of aggravate. There's a lot more going on with a bunch of different symptoms that we won't get into, but we'll kind of get it to what we found. So one of the other things is that you were on an intersegmental traction table. So you were left to your own devices and you turned it up. So the intersegmental traction was tractioning your head and neck, and that triggered you in a bad way. So one of the things that kind of set you up, well, is that you were born with torticollis. So as a baby, you had torticollis, and you had to wear a helmet at some point for them to kind of reshape you, protect your head. So there's some asymmetries in here that are making it difficult to define, to figure out the best way to adjust your atlas, and actually the rest of the story here. So I guess that we'll just go right to the most important thing, the biggest thing. Yeah, we adjusted your atlas and that helped, but really the problem is right here behind your jaw, and we're just going to remove the jaw. So just look right there. And this is what we found. So you were born with this really large, tortuous internal carotid. Look how it comes around. Look how it loops in through there. So when you get a hyperextension injury, a whiplash, any kind of injury to the front here, it plays out with symptomatology that is confounding. So you can even see how big, how it reaches into the mouth. And actually you chew gum all the time to try to get some relief. Chewing gum constantly seems to make a difference for you. And this is kind of what we found. So here it is, slice by slice. There's the internal carotid that has that loop, and here's the pterygoid muscle. So you can see how the muscle on this side is actually making contact with it. There's the normal on the other side, just a straight up, no space occupying compromise. Oh, and by the way, the internal carotid artery has a plexus of nerves that run around it, a sympathetic type of nerve chain. So the sympathetic nerves are getting irritated, and we could speculate a lot. Nobody likes to speculate too much, but when we went in through your mouth, and so we did it yesterday, and man, it was tough on you. God bless you. You let me get in there and move the muscles around in there. And today we actually felt that pterygoid let go and release, like hitting trigger points in there right at the atlas level, right in there. Let's actually, you know what? Let's finish the rest of the story here. So the normal side, this tortuous loop, and here we go. So we have asymmetries of the skull. The brain has asymmetry to it. So to find the exact best vector for the atlas, it ended up having to do with the midline of your head. Let me see if I get a better shot of it. There you go. So the best vector for your atlas, it ended up trying to get your atlas to match up with your brain. And why do we care about the spine so much? Is because it houses the neurological tissues, the brain and cord and structure. So you can see this line here, that ended up being the line that we matched with the atlas. And that helped some, but really it was going after the front of that, in front of the atlas. So yeah, when you were on that intersegmental traction, did you injure the back, the posterior atlanto-occipital membrane? Yes. Now that's where they can get to. They can inject all back in there real easily. You can get that in pretty much all over the place. But going in through the mouth, that's a different area. Okay, so let's see. Now we're just going down. We're going down into the neck. Let's go right to this torticollis that you were born with. So we can go right. There's the clavicles, and just pay attention to the SCM where it originates on the left side, and actually we'll show you that. So this contracted hyperactive muscle SCM on the left has contracted the facets on the left. So the left side of your neck doesn't even look like it's in the same person. The right side of your neck looks like a normal, really like no miles on it. And then the left side is all this contracted because of this. So we'll follow that up and see how large it is in comparison to the other. Then it joins from the clavicle. Again, you're comparing the two-sided muscles. So this torticollis that you were born with, I think, has played out your whole life. We're kind of going the wrong direction. Here we go. Look how big that belly is. So it's a spastic torticollis. So depending on what doctor you get in front of, I mean, some guys would do a dry needling to try to release that. Some people would do Botox in there. And again, experimentation beats theory all day long. So you find out what actually makes you feel better. We're not married to one discipline over another. It's multidisciplinary, multi-denominational, non-denominational church here. Okay, yeah. And by the way, since we saw that asymmetrical SCM, we looked for other asymmetries, and yeah, there's asymmetries through there, but nothing as demonstrable as that. Nothing that big. Okay. Oh, and by the way, that massive pain that you have at the base of your skull, your head. Well, here we go. Let's show some of these muscles. We'll go into that in a second. So there's the pterygoid. So what are we looking at? You have an internal carotid that has a loop to it. What muscles could have been aggravated and injured from that hyperextension injury? Well, we got the pterygoid that looks like it's making contact. We have the styloglossal muscle, and right in behind it, and I've seen with other whiplashes, other people get injured in through there quite significantly. It seems as though there's trigger points, and these muscles are displacing, splinting, guarding, all kinds of stuff in there. I've actually seen soft tissues that are invisible on the scan, but it seems like they're displacing jugular veins and stuff. So that's the rectus anterior capitis muscle. But when I went in there and got it to release, the whole thing let go, and we put you in a plastic collar to see how well you can hold. And by the way, to get you to hold this correction or this not aggravate this injury, we got you in a plastic collar. We want you to walk slowly. I've seen it to where the only thing that's keeping somebody from healing is they walk too fast and they have the head bouncing around or gyrating, and that's what seems to be holding them back. Let's see here. Here we go. Now we've got some screenshots that we run through. Okay, so from here you think adjust from the right, and adjusting you from the right worked until it didn't. Here again, looking from the front. Again, it looks up on the right. Oh, here you can kind of get an idea. You can see the facets. And by the way, the disc heights in front look pretty normal. The facets on the left are all worn out. The facets on the right are practically normal. All the left are kind of eaten up and showing a load. And you can even see how C2 pulls down. Actually, we got better shots of it. Now, I tried, let me see, did I go too fast? Yeah, I wanted to blame your levator scapula, but it seemed like your SCM. So from this view, this is actually the bottom of C1, top of C2. That would tell you to adjust from the right. We went a little higher. Now we're looking at the posterior arch. That would say adjust from the left. I didn't even draw a line through the center of your skull because your skull is so asymmetrical. We've seen other people that have had skull injuries, so that they have to remove part of the skull, so you can't use the skull as a metric. We looked at these condyles, so there were so many asymmetries. Your condyles are asymmetrical, but they're actually making up for some other asymmetries, and it ends up like they're canceling out, which was kind of tricky to figure out how to adjust you, and it came down to the brain tissue telling us. So, for example, there's your atlas putting pressure on the jugular, or at least bordering it, and your atlas is not anterior enough on the right. So when we increased the anteriority of the atlas on the right, it made you feel better. That it helped. But again, this anterior atlas injury, or the injury in front of the anterior aspect of the atlas, that tortuous internal carotid, seemed to be ground zero for your symptoms. Oh, and the good news is when we go in through your mouth and work on that, this occipital pain is significantly better. The problem, I think, just bouncing around from walking is going to make it come out quickly. So we'll figure that out. Yeah, so here you can see basically the left side is pulled down. So it's contracted here on the left, so the occiput has to go high to try to compensate to that. And that's what we were looking at, all these different compensations. Yeah, look at that. And there's your C2 that's significantly adapting. Yeah, I think one of the neat things, if you treat that contracted, hyper-developed left SCM, that's going to change the mechanics and the geometry quite a bit. And you're not going to be as vulnerable. I did liken this up to 5 guys watching one person in a ditch doing all the work, and everybody's just standing around watching them. We found that your neck is pretty much immobile, doesn't move very much at all, and all the motion is up at the top there. So that's what's getting beat up. So when you were on that intersegmental traction machine, the forces weren't being distributed through evenly. What took the hit is up here at the cervical cranial junction. Yeah. We spent a lot of time looking at different. Yeah, there's a good screenshot of that. That's a big difference. There's the sternal head, clavicular head that you see hypertrophied. Yeah, I mean, you go in the gym, you work out your muscles to get them bigger. So it looks like that left SCM is being hyperdeveloped. Okay, so when we saw all these arthritic joint capsules, we thought, well, should some force be put in there? When you think curve correction, you don't exactly think this is a more asymmetrical thing. The right side is going to move normally, easily, and it's the left side that's resistant. So then when you're contemplating put force through there, next thing you need to know is look at these vertebral arteries. Are they in trouble? Is there a joint capsule that's a calcification, a spur that's entrapping the vertebral artery? And when you look at it slice by slice, you can't really tell because they're always running close to the bone. But here, it looks like it's a little in a dangerous spot, and that is a C3 joint capsule that is making contact with the vertebral artery. So that would be, you'd have to be careful with anything you do there. Again, we traced that vertebral artery. We were interested in that. Again, we documented how much where you actually turn with neutral and right head rotation. Wanted to see what was moving and what wasn't moving. This is not moving. You have very little movement here. The atlas doesn't even seem to be moving too much. So we're not going to beat that up. Again, we inventoried the vertebral artery. Really cared about that. Any spur formation there. Again, showing the lack of movement, or the only place that is moving. There's the only segments that are, well, I put arrows where there is some movement. Again, trying to determine the best way to adjust your atlas. That's looking up, trying to get the angle of how the brain sits and as it enters into the foramen magnum. We didn't 3D model that. We almost did, but this ended up being the actionable information. So we matched that angle with the atlas, if you can believe such a thing. And then the vertebral arteries, is it the vertebral arteries that want to be lined up? Well, in your case, it seemed to be the brain, or the brain stem, spinal cord. We looked at a bunch of stuff. Left head rotation, right head rotation. Right, okay, so we didn't really get into this too much, but basically you have your concussion symptoms will come back with any jostling. Somebody shakes your hand too much or pats you on the back, and your concussion symptoms will aggravate again, and you'll be in trouble for a couple of days till it kind of goes away. So I wanted to blame the levator scapula. I couldn't find it to be hypertrophied, but that doesn't mean that it doesn't get in play. Right, so we went in there. I don't know that this was the trigger point that released. There was a band of muscle. It seemed like a pterygoid that let go. There's the internal carotid plexus sympathetic nerve And of course, this is showing a normal straight internal carotid. Here's loops. So you chewing all the time to try to relieve some of this makes sense. I'm not going to speculate too much. It's just we know that you got better when we released that. And then you wear this collar to stop the bouncing of the head. And we'll see the pterygoid. Yeah. Trying to find the exact muscle fibers that were in contact. Yeah, so there's a lot of beach sand. Everybody comes here, they get in the sand, and you got sand all over you. Yeah, so asymmetries. Anything you want to talk about? Anything you want me to mention that I might have not mentioned?
I think you've been very thorough.
Okay, good.
You've gone over everything in detail, and I appreciate it immensely.
I'm glad you came. I learned a lot. Thank you.
Well, thank you. Okay.